All right. Hi, everybody. I think most of you guys know me. I'm sorry, I'm in speaker mode, so I can't see anything besides my slides, but thank you all for joining. I'm Hannah Ryles. I am one of the complex gynecologic and surgery attendings here at U of Chicago. I was a fellow here, so a lot of you guys I recognize from when I was in fellowship. So I just ended my fellowship in 2025 and then started on as my attending year. This has already been a year, which is crazy. So I have CCGY in CCAM, so I see you guys all a lot during that time. But thank you so much for having me. I'm going to talk about laparoscopy and hysteroscopy and really just like a practical guide for what you need to know for when you're kind of having those patients on the phone or seeing those patients in clinic and kind of what to expect. So first, disclosures, I consult for this company called Expect Fitness, and then just going over what we're going to cover today. So first, we're going to go through laparoscopy and go through all these different teaching points, and then we're going to go through hysteroscopy and all these different teaching points. So first, laparoscopy. The common indications that we refer patients to laparoscopy for, we'll go through that. So there's a bunch of different reasons, and I'm sorry this slide is really busy, but essentially anything that's going on internally in the pelvic region, in terms of the abdomen, we often will talk to these patients about diagnostic laparoscopy and or treatment with any of these other things. So what's really nice about minimally invasive methods these days is that we can actually just very easily take a look. Our imaging is getting much better with our ultrasounds, but really if we need to assess something internally, we can do it laparoscopically. So I'll go through the incisions, but the nice thing is that it's not as morbid of a procedure as it used to be with like an exploratory laparotomy. Nowadays, it's minimally invasive. So these just I'll briefly highlight are a couple common reasons that patients need laparoscopy. So endometriosis, which is part of my specialty. A lot of patients who have pelvic pain might have endometriosis, and sometimes this does not show up on imaging, even our dedicated ultrasounds or MRIs. And so sometimes we are doing laparoscopy to take a look at that. Another part of my specialty is fibroids, and so sometimes we're looking at their fibroids, sometimes we're also removing them, so in something called a myomectomy. Ovarian torsion is a emergency cause of needing to get a laparoscopy. That's if the ovary turns on itself and it causes a sudden loss of blood supply, so it can cause a lot of pain. Ovarian cysts and masses, oftentimes we're taking those out. Ectopic pregnancy is also another surgical emergency. And then there can be kind of adhesions and infertility workup and things like that. So those are just common indications. There's a bunch of other indications that we do laparoscopy for. So procedural considerations, so kind of going through how it actually works. Oftentimes for laparoscopy, there's 2 to 4 incisions and they're really small. So I always tell patients it's about the width of my thumb is one port site. Usually for a standard laparoscopy, you're going to have 3 or 4 incisions. Oftentimes when we're doing something robotically, they'll have 4 or 5 incisions and they're all, again, really, really tiny. Oftentimes we're entering through the belly button, so it's the umbilicus, and then 2 on each side. If it's a robot, if it's just what we call straight stick laparoscopy, that's usually 3 or 4 incisions. And the difference is, one thing to clarify is oftentimes robot is considered, it is considered a tool for laparoscopy. So it's robot assisted laparoscopic X procedure. So for example, robotic assisted laparoscopic myomectomy. So we're just using the robot, but we're still doing things laparoscopically, meaning small incisions and inflating the belly with gas. And so I'll go through that. Oftentimes so as I mentioned, the incisions can kind of be throughout the whole belly, but they're most often placed in the belly button, kind of near that area. Laparoscopy relies on using carbon dioxide gas pumped into the abdomen through the ports. And so we inflate the whole belly with gas and it fills that space that's kind of a potential space to make it a working space for us. And then the way that we going into Trendelenburg positioning is the way that we work in the pelvis. We often have patients they have to be turned on their head a little bit. That's called Trendelenburg. And that's where their head is tilted 15 to 30 degrees downwards to shift the organs out of their pelvis in order to give us working space into the pelvis. And so the reason I mention all of this is because this can affect both patient it can lead to certain complications, and it can also affect the patient experience. So things that can happen with Trendelenburg positioning is that they can get nerve injuries. So especially patients with higher BMI can have extra pressure on their nerves due to the positioning. And so they can wake up with kind of numbness of one arm. I think, prior to my training, I would hear numbness and I would think, oh, they must be concerned for like a stroke, which is definitely a complication that can happen in any surgery. But the more common things being common is nerve injuries, kind of like a carpal tunnel syndrome or a brachial plexus nerve injury that are usually transient are much more common. Other things that can happen is patients can get kind of eyelid swelling because it's almost like being tilted on your head for sometimes these surgeries last anywhere between 4 to 8 hours. And so sometimes patients get like eyelid swelling. You can get swelling of your internal part of your eye as well. And so there's a lot of different things that can happen with the positioning for laparoscopy. With anesthesia, the big thing to know is for laparoscopy, because we're inflating the belly with gas, the diaphragm isn't able to breathe on its own kind of as normal. And so all of the patients getting laparoscopy has to be under general anesthesia. I think that's an important point, especially for the nurses. If you're counseling patients, I have recently had a string of a lot of patients who are nervous about general anesthesia, and they kind of asked if laparoscopy can be done under like monitored anesthesia or twilight or anything, but unfortunately it cannot, because we're inflating the belly with gas. We have to breathe for the patient during the surgery, and so there's no way to do laparoscopy without doing it under general anesthesia. And so there's certain complications that come with general anesthesia, but generally it's a pretty safe thing to do. So these are just some pictures of laparoscopy. This would be considered what we call straight stick laparoscopy, which just is the alternative to robot. So there's robot laparoscopy and there's straight stick laparoscopy. This is an example of straight stick laparoscopy where in this example, I don't know if you guys can see my cursor, but this camera is placed through the belly button here at the top. This curtain would be hiding the patient's head. These are usually there's one surgeon on one side and then the resident or assistant on the other side. And then these are 3 ports. So this is a suprapubic port that's kind of above the bladder, and there's 1 port on each side. And so these are the typical instruments that we're using. And we're using this camera and kind of looking around. So this is another picture that I think is really helpful to kind of understand like what we're doing. So this picture is showing a cross section. The laparoscope is showing inside the pelvis. This picture is good, but it's not perfect because it doesn't show the patient in Trendelenburg positioning. Trendelenburg positioning would be that the uterus and things are kind of this way, and the head would be this way at kind of a degree of an angle. And so that way all the organs kind of flow towards the head. And so that way we have free working space in the pelvis. This is just another picture just showing kind of the setup in the OR because we are positioned this way and then we're looking at a screen. So everything we're doing is we're translating 3D structures into a 2D image on the screen. So this is just comparing different incision types. This is if you like kind of back in the old day, people oftentimes had like open surgeries. And so oftentimes it would be like something called a midline vertical incision. Oftentimes people are trying to do a fan and steel, which is like a C-section cut incision. But if we can do it minimally invasively, we can do it through these small little incisions. These are typical locations of port sites for our procedures. So some pre-operative considerations. Oh, and please feel free to unmute yourself and ask me any questions at any time. I want this to be interactive if we can. So pre-operative considerations, what happens before the OR? So patients come in for their surgery. The surgery gets scheduled. We request the surgery date. They are often seeing anesthesia beforehand to make sure that we've held their appropriate medications, to make sure that their past medical history is reviewed, and that we kind of get the clearance to go ahead to do the surgery. On the day of the surgery, patients need to come in 2 hours before the surgery. So like, let's say a surgery is scheduled at 9 a.m., they'll have to come in at 7 a.m. And oftentimes we are getting labs that day. We're checking the patient in. We need to make sure that their status, that they've been not NPO. So they've been NPO for generally after midnight, that they haven't eaten anything because oftentimes that will delay. And this is all because of the general anesthesia. And so there's a risk when you have general anesthesia that if you've eaten recently that you can throw up and it increases your risk of aspiration pneumonia. And so that's why we have to make sure that they haven't eaten anything. These are all just some other preoperative considerations. And so the other big thing is because they'll have had anesthesia, regardless of if it's general or, as I'll go into for hysteroscopy, twilight anesthesia or MAC, any type of anesthesia, you need a ride home. And so I always talk to patients beforehand, making sure that they understand that they will need a ride home because they won't be able to drive themselves home or take an Uber or anything like that because they'll still be sleepy the day of the surgery from the anesthesia. So moving on to post-operative considerations. After the procedure, in terms of recovery monitoring, after the procedure, the patients go back to the recovery area where they then have about maybe like an hour to 2 hours to recover. The post-op nurses are checking their vitals, checking their pain, oftentimes making sure that they pee because the Foley catheter is often placed inside during the time of the surgery, and then we remove it right before they wake up. And we are kind of making sure that they have a safe place to go home. Discharge medications, this is kind of particularly helpful for the nurses, is generally what a lot of us send afterwards is oftentimes we're sending something called tramadol, which is a opiate type of medication. We're often sending this instead of oxycodone. It works very similar to oxycodone though, so it is a opiate medication. So for a typical laparoscopy, I'm not talking about like a hysterectomy, but for a typical laparoscopy, so for example, laparoscopic excision of endometriosis or laparoscopic cystectomy or a laparoscopic salpingectomy or treating an ectopic pregnancy. So for those kind of typical laparoscopies, we're often sending 10 tablets of tramadol, 50 milligrams, but we are also sending Tylenol and ibuprofen and an anti-nausea medication often. So the big thing is that at least I always counsel my patients to take the Tylenol and ibuprofen scheduled around the clock for the first couple days because that's really going to help with the baseline pain and inflammation. And then I tell them to take the tramadol on top of that if they're having severe pain. I also spend a lot of time talking about kind of pain expectations because after a surgery like this, it's going to be expected that they're going to be anywhere between the 3 to 7 range on the scale of 0 to 10 pain scale, but they should really take the Tylenol ibuprofen to keep them below a 5. And then the tramadol they can take, generally I tell them if their pain is about a 7 out of 10. So common patient complaints and what patients experience after laparoscopy. So the big one is shoulder and neck pain. So that's a very, very common complaint after laparoscopy, and I see it very up to 80% of the time. And so that's what patients honestly most often tell me is the worst pain after any of these laparoscopic surgeries. So that's laparoscopic hysterectomy all the way up to, laparoscopic myomectomy, kind of anywhere in between. Patients will often report this shoulder and neck pain. And what that is caused by is the gas that we use to inflate the belly is inside the abdomen, and it often will irritate the diaphragmatic nerve, which is actually running underneath the diaphragm inside the abdomen. And so it's just gas living underneath their diaphragm, but patients experience that as actually shoulder and neck pain. So almost always the patients are kind of coming back to us or calling with this severe pain all throughout their whole neck and oftentimes their shoulder. Sometimes it's one-sided, sometimes it's both sides. But the problem is that it's not very well relieved by the typical pain medications. So things like the opiates like oxycodone or tramadol don't usually help with it. So the best thing that I tell patients to help with that is really trying to ambulate because that gas that's inside their abdomen is going to diffuse throughout their bowels and then eventually they're going to pass it as farting. And so as much as they can fart, unfortunately, is going to make them feel a lot better. That kind of extends to the next common experience that patients have after laparoscopy, which is abdominal bloating and gas pain. So this is, again, sometimes we see patients in the ED for this type of pain because it just feels really, really bad, like they can't fart, but they really want to. And so for that counseling, we kind of just tell patients to walk as much as they can tolerate, and then try to avoid things that are going to make them more gassy. So avoiding kind of beans and carbonated drinks. And then Gas X helps a little bit for some people, but I mean, the evidence doesn't show that it helps that much, but honestly, if they want to try something, also it's not written on here, but trying chewing gum can help as well. Other things that patients commonly experience is incision site discomfort. So a lot of times patients find they'll have mild soreness around their incisions, but most often the two things I'm getting when I talk to patients the day after their surgery, the two things that most patients report are the worst are this shoulder type of pain and the abdominal bloating. Most of the times they're like, my incisions feel fine. It's just this bloating and pain. Some of the things that can happen is kind of fatigue and nausea. So because they'll have gone fully to sleep, a lot anesthesia can make people feel really, really tired for a couple of days, and that's just because of the way that it works in your system. It usually wears off within a couple of days, and then nausea can also happen. So nausea is very common for our patients in our age group, and so oftentimes we are sending them home with anti-nausea medications, but sometimes they need even additional anti-nausea medications. Vaginal spotting or discharge is often very common too, because a lot of our procedures we're actually using something called a uterine manipulator to help move the uterus around, and that can cause spotting and bleeding for the next couple of weeks. Sometimes their cycles are offset, and that's totally normal. Urinary symptoms can happen sometimes as well, with pain with peeing or difficulty peeing because they've had a Foley catheter in their bladder during that time, but oftentimes that gets better as well. So just briefly, I'm checking time, just briefly to go through rare complications. And so these are things just to know so that you can know when to escalate early. So some rare but very important complications are vascular injury. So during the surgery, there can be injury to vascular structures. So that's your vessels, including your aorta or other major blood vessels. Usually we notice this if it were to happen at the time of the surgery because it's pretty obvious. Patients usually will show vital sign abnormalities pretty quickly, but there can be small injuries. So one thing that I want to mention in terms of vascular injuries, there's times where patients have a blood vessel, like a superficial blood vessel near their port site that just keeps bleeding and bleeding and bleeding. We've had patients that have had to come back for that as well. The bowel injury is also something just to note that can happen. Obviously, if we were to see evidence of that at the time of the surgery, we would repair it, but there are times where we don't notice it. Or thermal injury can happen because some of the instruments that we're using actually have electrosurgery, which uses essentially electrons to create thermal injury, or sorry, thermal injury and or sealed blood vessels. But that can actually spread to nearby organs and cause injury to the small bowel or other organs. And so bowel injury is particularly dangerous, and it may not show up until 1 to 3 days after surgery. And patients will report with kind of vague symptoms, but worsening abdominal pain, fevers, chills, abdominal distension. And if you're ever at all worried about that, that's something that you should send the patient to the emergency room right away. Bladder injury can also happen as well. Usually, if they have blood in their urine, that can be a kind of clear early sign. If they've had stents placed, they will generally have blood in their urine, so that's kind of not helpful. But if they didn't have stents placed, generally most patients aren't having blood in their urine, so that is something to kind of, you can always reach out to the surgeon and say, hey, like this patient's reporting blood in their urine, is that expected or not? If it's not expected, that is concerning for a bladder injury. That is more likely to happen from kind of either a very extensive endometriosis excision surgery or a hysterectomy, especially if they've had like prior scar tissue. So other things are like you can get a gas embolism. I'm not going to spend too much time on that because that's very rare. Hernias can happen after their port sites. Again, the port sites are really tiny, about the width of my thumb, but they can open up at any point or they can kind of extend and bulge out. Generally, those are not very dangerous unless bowel were to get stuck in there, and patients would report like all of a sudden severe pain in that area. Nerve injury, I kind of already talked about that. That essentially you just want to make sure that that's getting better over time. Generally, those patients with nerve injuries, we just do supportive care and they improve over the next couple of days. In rare cases, patients need physical therapy to help with their nerve injury complications. Okay, any questions from the laparoscopy part? Okay, I'm going to move on to part 2, which is hysteroscopy. And so the nice thing about hysteroscopy is it's truly minimally invasive. There's no incisions. You're just looking inside the uterus. And so I always talk to patients about that it's, um, I think a lot of times I spend a lot of time saying hysteroscopy. Hyst means uterus, oscopy means camera, because a lot of times patients, when I consent them for a hysteroscopy, they're like, wait, I didn't think I was doing a hysterectomy. And so sometimes patients kind of get nervous about that. I see something in the chat. Oh, okay, whoops. Oh, so going back to the hysteroscopy, again, oscopy means camera, like colonoscopy, and so we're taking a look inside the uterus. So why are patients referred to hysteroscopy? There's a bunch of different reasons actually. And so one of the most common reason is actually abnormal uterine bleeding or postmenopausal bleeding. So this is patients who, for whatever reason, there's been a change in their menses and their periods are just much heavier, and they meet criteria that we need to do endometrial sampling. And you can offer the patient's endometrial biopsy in the office, but as you guys probably know and have seen from supervising these procedures, they're extremely painful. And so if a patient wants to avoid that, there's no problem. They just will need a hysteroscopic sampling. And so that's while they're asleep. So oftentimes for abnormal uterine bleeding, we can remove polyps, we can remove fibroids, we can treat these are a little bit more rare types, so like treating miscarriage or scar tissue inside the uterus. Endometrial ablation is kind of another procedure where we heat up the endometrial tissue to kind of reduce the amount of bleeding. Oftentimes I'm talking to patients about getting an IUD at the time of the hysteroscopy because that can help reduce their bleeding in the future as well. So procedural considerations. So this is actually what it looks like. This is a hysteroscope. This is showing an example of a flexible tip one, which we don't have here. But this is like something if we were doing in the office, but basically it looks kind of similar. So you have a speculum and then you are putting the camera into the uterus and taking a look around. So that's why there's no incisions, because it's actually just going through the opening of the cervix. This is a kind of a better picture of a hysteroscopy, so that way you can look inside the uterus. This is what it actually looks like. We're just taking a look inside the uterus. You distend the uterus with fluid, so it's usually some type of saline fluid that can help open up the uterine cavity, and so that way we can kind of look inside. There's a light on so that way we can see inside. This is what it looks like. And sorry, this picture is actually just from Google to show what it looks like actually inside the uterus and when we're looking at that on the screen. So how the procedure actually works, sorry, I'm just gonna have to move over here. How the procedure actually works is that you have the camera that looks inside the uterus and you take a look around. We actually do have instruments that can help look into the uterus and actually help shave down certain fibroids and remove polyps and all these things. And so anesthesia, the big point about this one is that you actually can do this procedure under twilight, and you actually can do this procedure under even local anesthesia. So we sometimes will do this actually in the office. We now have the ability to do office hysteroscopy. And so that's actually without having to go to sleep at all. So you don't have to go to sleep for this procedure, but you don't have to go to sleep for this procedure. So that's another big thing to talk to patients about. Generally, I would say most patients are getting this procedure under something called monitored anesthesia care, which is MAC. And that can be a way to, again, do this procedure when the patient's not fully asleep. In order to see inside the uterus, we often are using a fluid to distend and open up the uterus. And so that helps us see inside the uterus and remove any things that we need to remove. For positioning, most patients are kind of laying down and in dorsal lithotomy. Oftentimes, we are not needing any positioning changes, so they don't necessarily need to be intranuclear. So preoperative consideration. So before the procedure, again, this is endoscopy, we're checking the patients in. One thing I just want to mention here is that oftentimes, for patients who have any risk factors for something called cervical stenosis, which is where the cervix won't open up, we can send a patient a medication called misoprostol or Sedotec. And I'm telling the patients to place this inside their vagina the night before the hysteroscopy. And that actually helps soften up the cervix and helps us make sure that we're successful with proceeding with the hysteroscopy. So in terms of post-operative considerations, one thing, I'll go into that. So in terms of post-operative considerations, it's very similar. It's a same-day procedure. The big thing for people to know is that we are generally prescribing just Tylenol and ibuprofen after this, and we don't necessarily ever prescribe any opiates for this type of procedure. Generally, patients tolerate this very well, and so most of the time, patients are like, "Oh, I did fine. It didn't feel like I had that many cramps afterwards." And again, they're actually generally back to work by the next day. So sometimes patients take, 1 to 2 days off. I'm generally, you can take up to 2 weeks or kind of more if you wanted to, but most patients are really only taking a couple days off for their hysteroscopy. I have had patients go back to work the next day, and that's okay. There's no lifting restrictions or anything like that. The one restriction is that we recommend nothing inside the vagina for at least 2 weeks after a hysteroscopy, and that's to reduce the risk of an infection. And that's because we open up the cervix. We want to make sure that, bacteria and other types of fluid don't get inside the uterus. So common patient complaints. And so this is, sorry, a little short just because, as I mentioned, patients actually don't have too many issues afterwards, but it kind of goes into the rare complications, and I'll make sure I go through that so we can know those kind of going forward. So in terms of more rare but important complications to be aware of, something called a uterine perforation. That's actually the most rare but most dangerous complication that can happen. And that's if one of the instruments, so the camera or any of the instruments that we're inserting into the uterus, because we have to dilate to open the cervix, if any of those instruments were to go all the way through the uterus, that's called a uterine perforation. And that can cause, if it's in a certain area, it can actually damage the bowel or major vessels. So sometimes if we are concerned that that happened at the time of the hysteroscopy, sometimes we need to do a laparoscopy at the time of the hysteroscopy to make sure there's been no damage to the surrounding structures. Again, that's very rare. The risk factors for that are stenosis. So if the cervix does not open up very well for whatever reason, usually if the patient hasn't had any vaginal births before, or if they're older. And so that is something that is pretty dangerous, but it's fortunately very rare. Fluid overload and hyponatremia. So patients actually get quite a bit of fluid from this procedure in their uterus. And so they can get too much fluids. It's almost like they're getting 2 to 3 liters from below, but it goes into the systemic circulation. And so sometimes patients, especially with those with underlying comorbidities such as congestive heart failure or COPD or other conditions, are at higher risk of dangerous things happening if they were to get too much fluid. Hemorrhage can happen, but generally this is from a complication happening, or if there was a very large fibroid that was removed, or a laceration on the cervix, so it's like a cut on the cervix. So that can happen, but it's pretty unlikely. Cervical laceration, as I just mentioned, that's sometimes we have to use a tenaculum to hold the cervix in place, and if those pull through, sometimes you can kind of get a tear in the cervix. Infection is very rare from hysteroscopy, but it can happen. So any fevers after a hysteroscopy, we always tell patients to kind of let us know and make sure to kind of keep an eye on it. There are times where we had to readmit patients to give them antibiotics. Asherman syndrome is just something to note, is that after a hysteroscopy, you can create scar tissue inside the uterus. And that's something I counsel patients on if I'm removing a fibroid, which is the most typical cause of causing Asherman's. Okay, or in the GYN world. Okay, so part 3, pre, intra, and post-op. I want to go through quickly because I want to make sure there's time for questions. But pre-operative things to know, this is actually a little bit more for the pre-operative team, which we don't work here, so I'm going to skip over that. And so intraoperatively, the most important thing is just knowing that generally for laparoscopy, we are doing the CO2 insufflation of the abdomen and Trendelenburg positioning. So for hysteroscopy, it's just kind of knowing that the patients often report or have a lot of fluid that they've gotten. And so kind of going over that as well. We generally do send everything off to the pathologist, and so the specimens usually come back in about 3 to 5 days before we can let the patients know about the results. So post-op responsibilities, this is also geared a little bit more to the PACU area. And so these are kind of just universal teaching discharge points. Wound care is very important. So I usually place steri strips along the incisions, and I usually tell patients to let them fall off on their own in about 7 to 10 days or 2 weeks or so. That helps that area heal very nicely. Nowadays, almost everybody is using dissolvable skin suture and then the steri strips on top of it. Things to note is that, as I mentioned, no submerging in water. So no baths, pools, or hot tubs until 2 weeks for laparoscopy or hysteroscopy. And that's just to avoid an infection. For laparoscopy, we recommend no driving for 1 day after anesthesia, longer if you're taking opiate medications. We recommend no heavy lifting for greater than 10, no heavy lifting above 10 pounds for greater than 1 to 2 weeks. We recommend to start walking pretty quickly because it helps with the gas pain. Also included in the, we call it pelvic rest, so nothing inside the vagina for that first couple of weeks. And then return to work. I forgot to mention this for laparoscopies. So for standard laparoscopies where it's like a laparoscopic excision of endometriosis, generally, it says 3 to 5 days here, but sorry, I should edit this. Most patients are taking about 2 weeks off of work. For a physically active job, I definitely recommend that. For kind of a desk job, patients can go back theoretically in a couple days, but most of them are going to want to take off like at least a week or so. For a hysterectomy, that's when patients are taking off that longer stretch of time, so 6 to 8 weeks, sometimes longer. For hysteroscopy, there's generally no activity restrictions. And then these are just some of the signs and symptoms of when patients need to go to the ER. So any fever after a surgery is not normal. I would say it's probably something that you need to get evaluated for. Any heavy bleeding and I always spend time talking to patients about what constitutes heavy bleeding. That's soaking through a pad front to back, side to side, more than 1 pad per hour. And so if they have that heavy bleeding, but it stops, that's not something that they necessarily need to go to the ED for. But if it's heavy and it does not stop, that's when they need to go. For severe worsening abdominal pain, and then other things are like signs of symptoms of a DVT, so shortness of breath, chest pain, or calf swelling, inability to pee, or signs of infection, or just feeling confused or possibly an anesthetic complication. So here are the key takeaways in summary. I'm not going to read it. I'm just going to leave it here for a second and see if anyone has any questions, and go from there.
Thank you so much for doing this. It was so comprehensive. I think from my perspective, especially when I sit in on the nurse manager meetings, and we're relaying, often they are relaying some of the questions that their nursing teams have. They really do come down to a lot of the pre and post-op call conversations. So I don't know how, I didn't look to see how many nurses were on, but I'm sure many will look at this afterwards. And you did touch on it, but I just thought just to hone in on,
Yeah.
kind of the key things to tell patients beforehand, like when you're doing the pre-op call, and some of the key things again. And I know you did a fabulous job on the slides of like going through some of those high acuity buzzwords of when you want to escalate things, but some of the key things to look for post-op. I think those are kind of the big issues that our nurses see. And then from the MA perspective, I think they are, when they're rooming the patient, and then, they can set us up for success by already asking patients those really key questions as they're rooming them. So if for the nurses, you could go over some key strategy things for the pre and post-op calls, and then for the MAs, the key things that we want to know what's happening when we see them for that post-op visit.
Definitely. Those are perfect points. So for the pre and post-op, I'll tackle that first. For pre-op phone calls, I think it's hard because laparoscopy is a huge category, so it really depends on like what type of laparoscopic surgery they're getting. But I'll break down laparoscopy in kind of like minors and majors. So minors are anything where like the uterus, basically, if the uterus or fibers are not coming out, it's kind of considered a minor laparoscopy versus like a laparoscopic myomectomy or laparoscopic hysterectomy are kind of considered majors. And so for laparoscopic minor procedures, things to go over preoperatively is just, making sure if they were to have seen anesthesia, that that was obtained, making sure they understand where to go at the time of the surgery, making sure that they um, understand the NPO requirements, so nothing to eat after midnight. And that's kind of the big things for the laparoscopy. And then post-op considerations. So for time off of work for the laparoscopic minors, so that's again things like laparoscopic cystectomies, laparoscopic salpingectomies, laparoscopic excision of endometriosis, laparoscopic oophorectomy, so removal of the ovaries, other kind of laparoscopies that don't include removing the uterus. Generally, again, most patients are taking about 2 weeks off of work. And so every now and then it's different, but I would say most patients are taking about 2 weeks off of work, sometimes shorter, sometimes longer. There aren't generally lifting restrictions for that, but sometimes it depends because essentially if any of the small incisions had to be extended, there might be some lifting restrictions, but for those minors, it's not quite as extensive. I'm trying to think if there's other things for the minors. So that's for that. But then for the laparoscopic majors, so that's things like a hysterectomy or a myomectomy, that's a much bigger surgery. And so generally patients are again taking that 6 to 8 weeks off of work, sometimes longer. And there are lifting restrictions. So we generally tell patients not to lift anything above 10 to 15 pounds for 6 to 8 weeks afterwards as well. And then in terms of kind of things to look out for, so I think that when you're doing those post-op calls, these are all the complications. Hopefully you can still see my screen. These are all the complications that can happen at the time of laparoscopy. And so my kind of one point is that just always maintain a high index of suspicion. I can only speak for myself, but I would very much rather, if anything seemed off with the post-op call, just route it to me. I think most of the attendings would feel very similarly. Like we'd rather be safe than sorry because our op notes are always only so thorough. So like if something felt off about a patient, like let's say she's just having more nausea or it's post-op day 3 and she still hasn't passed gas yet. Or just something just feels off, I think sending a message to the attending surgeon would always just be a little bit more playing it safe, essentially. So,
Probably,
um,
I will add a caveat to that though, because if we're in surgery or in meetings, we may not get that epic note. So if there's
oh yeah,
any
that's true.
any person that someone is concerned about, I think just getting them in, either
Yeah.
advising them to come in and trying to find a same day appointment for them. Certainly, we can
Mhm.
be, I think, page or reach out to us by cell phone. I think Epic isn't always a good messaging thing if we
That's
are
true.
busy with other things,
Yes, Epic
especially for
message
a
is
high
probably, yeah.
acuity patient. And don't forget about our urgent care ability to get patients into. So they,
Yes, definitely. Like if you're very concerned, definitely like don't just send an inbox message. I agree completely. Like if it's something that you're pretty concerned about, I agree with Dr. Christmas. Just kind of I would page Epic Chat and see if we don't see it, and then page, call, or just try to reach somebody on that team. I've had people reach out to me about, people in my section. Needing to reach someone in my section, and I've been able to kind of help go through op notes. So just trying to reach someone if you're at all concerned. But if you're kind of minor level concerned, try to reach out because I think it's always better. More communication is always better than less communication, I would say. Um, and then for hysteroscopy, complications are pretty rare for hysteroscopy. So again, most patients do very well. The most common thing that people report is just kind of a little bit of mild cramping. But you do also have to maintain a level of suspicion for that as well, because other things can happen. So all of these other things can happen as well. So I would just recommend, you know, the pre-op considerations is very similar. The one thing that's different is sometimes patients are getting cytotec, which is that medication that goes inside the vagina to help soften the cervix. And then post-op considerations, it's just making sure the patient's doing okay. one other thing I wanted to mention is that if they had a hysteroscopic myomectomy with a resection, oftentimes they'll have passage of tissue that's kind of coming out for next couple of weeks, and I always talk to patients that that's normal. Again, if you're ever not sure, you can ask somebody, but that can be normal after a hysteroscopic resection. And then in terms of MAs, kind of when rooming patients, I think so for hysteroscopy, for patients who had had a hysteroscopy, they're generally not coming in person for a post-op visit. But if they are, sometimes it's because we place an IUD. And so I'm not sure if there's like a general rule to keep them clothed or unclothed. I generally like my patients to stay clothed and then they can get unclothed later. But for laparoscopic patients, we're always going to be looking at their incisions. And so oftentimes they can just like pull up their shirt. They don't actually have to get fully unchanged for that. And yeah, so it's mostly like an incision check and then making sure that they're doing okay. I think that was the questions.
A question you mentioned about the cytotech. What is your recommendation with regards to when they should put it in prior to the appointment?
Sorry, Toledo, I think you just said something, but it cut out.
When a patient has an appointment and they're instructed to use cytotech, what is
Yeah,
your recommendation? How soon in advance before the
Gen
appointment?
generally one day before the hysteroscopy is scheduled. So let's say someone is scheduled for a hysteroscopy on Wednesday. We tell them to put the cytotech inside the vagina the night before the surgery.
Okay.
Good question.
All right, everybody, this is your last chance to ask Dr. Ryles any questions. Did anybody else have any additional questions? All right, well, thank you so much for doing this.
Of course.
As always, you guys can get CME credit for these. So please go through the process and put the CMN code in. And it will be recorded and saved on YouTube and Boometi, and we'll be sending out the recording to everyone after this session. Thank you.
Awesome. Bye. Thank you.
Thank you.